le débriefing de ce qui a été discuté, groupe par groupe. Donc, je vais inviter le groupe 1. Voilà. Nous n'avons pas perdu de temps, on est à l'heure, donc nous n'avons pas perdu quelques minutes simplement, mais nous allons demander au groupe 1, the group 1, to present the debriefing of the working group. C'est Estelle, yes. Estelle ou docteur Tundi. Parfait. Ok. Docteur Estelle, vous allez commencer. Le groupe 1, nous présenter vos conclusions du travail de groupe qui a été fait. C'était le plus grand groupe. Donc nous espérons que ce groupe va répondre aux objectifs attendus dans cette discussion, que ce qui a été exigé, demandé, sera donc présenté à l'Assemblée, à tous les participants. Donc je donne le micro à Estelle. Merci.
So we had a discussion on the action plan for each of the 4 new skin entities integrated in the LABNet.
Je souhaite que vous présentez pour que tout le monde puisse bien suivre. Il est mieux qu'on partage ça ensemble. Donc je souhaite que vous présentez sur l'écran. Merci. Ça ne fait rien.
Est-ce que c'est bon? Okay. So this morning we work on an action plan for the new skin entities integrated in the LABNet. So the common plan is to finalize the SOP concerning the sample collection as soon as possible. So after, for each of the 4 skin entities, we developed and underlined some aspects. So first for mycetoma, the Wendy lab are evaluating the generalized kit and master mix coming from Solis Biodine. And then after this evaluation, they will design a multiplex mycetoma assay. So the expected time is around 1 year. And at the same time, a collection of samples will take place in Senegal. So for this, they need a connection with the national program and a training on how to get the correct samples. So the dissemination of the soap for the sample collection will come from the lab of MRC. And actually, there are some student staff in the lab of Wendy. So for the budget, Wendy lab will cover a part of the harmonization procedure, but not all. Then for cutaneous leishmaniasis, the Javier labs are going to optimize the qPCR procedure to use the same reagent as BU. They are preparing the SOPs, and for the SOP that concern collection, it will be ready before the end of the year. Then they also have some samples coming from Ghana. They already have it on the lab. So they are going to evaluate the qPCR procedure directly on these samples. So the expected time for this is around 1 year, and the lab will cover the cost of the harmonization procedure. Then for the use, there is a need to validate the extraction method on dry swabs. So there is a need to get new samples from the field. They want to evaluate in at least 2 sites for to compare the soaps. And then they will also design a multiplex qPCR assay. If the evaluation is done on these 2 sites, the SOPs will be ready in the next 6 months. There is also the problem of the resistance, how to monitor it. So it will be the second step when the SOPs for the qPCR detection will be in place. So all this work will be done on 1 year, but they need some funds to collect samples on the field and for the regions. So this is why Serge is preparing a realistic budget for 2 sites of evaluation. Then for leprosy, soaps are ready, but we need to ameliorate the SOP for concerning the sample collection and to precise what kind of samples can be done and at which level in the health system it can be done. Also, the need of the collaboration with the national program is clearly necessary, and it is the first step to start the surveillance system for antibiotic resistance in Africa. So then there is also a comment on the use of the swabs, because for 4 diseases, BU, leprosy, Yos, and CL, we can use swabs. And it exists a kind of swab that is called Copland swabs that is really useful to increase the DNA release into the suspensions. So Sarah from ITM proposed to contact the company to see if they can obtain some of these swabs for the country in the BU-Lab, in the Skin and TDs LabNet. Okay, so I think I finished to summarize our discussions.
Merci Estelle. Voilà, résumé le travail du groupe 1. Je laisse le temps de poser des questions, des incompréhensions dont les micros sont ouverts s'il y a des questions par rapport à ce qui vient d'être présenté. Dr. Sarah est déjà prête.
Thank you, Estelle. Thank you to the entire group. So you just mentioned AQA for yours. Already ready, but you did not mention EQA for the other diseases.
Yeah. So yeah, EQA prototype is already ready for yours, and for the other diseases, I think we need to work on it. I don't know. Yeah.
Other question? Dr. Kingsley.
For leprosy, what kind of swabs are we talking about? So let's be clear also. We have wound swabs, which we will take from Burole, from yours, from cutaneous leishmaniasis. I don't think it's wound swabs in leprosy, so I think we need precision on what kind of swab so that people don't get confused on them.
Vas-y, Estelle, si tu peux expliquer ces différents...
Yeah, in fact, we use fine to collect the skin smears collected from ear or patch. So after it's easier to collect on a swab and send to a lab, and then we can have a suspensions by radiation of the swab directly in the water. So we don't take directly a swab from the lesions, but we use swabs to collect the skin smears.
Just to clarify, so sample collected in a tube with liquid and then swab dipped in and used it for transport. So I think that's the protocol many people are following now, so, which is easy rather than transporting the tubes with the liquid. So.
I'm talking about the collection. In Borole, in yours, in CL, we know it's a wound swab. So you have to see a wound and take the swab. In leprosy, it will be taken like how? That's what I'm trying.
Okay, it's a slit skin scraping directly. So it's a scalpel involved, isn't it, Estelle? Yeah. It's a slit skin scraping, put into a tube, and then transferred to a swab for transportation, not a swab of a lesion or anything. So it's a different, yeah.
Made
yeah,
to avoid confusion. Yeah.
Other question? Dr. Sej.
I'm just adding some comment about the collection of swab with in leprosy. It's just for the earlobes, slim skin, when the skin is open. After collection of fluid for microscopy, you need also a swab to collect that liquid in the open skin. I don't know if I explain well.
Kingsley.
To Serge,
Okay.
I think he was asking a technical question. Normally, that's not really encouraged because once you scrape the tissue there with the scalpel, although it's a very fine liquid, the material is lost. Like the material is already transferred, so the second swab in the same area may not really fetch a lot unless it's a highly bacillated case. So we encourage to transfer it to a liquid, put the swab in, and then take the swab for transportation purposes.
This is Monsieur Kwaku de Côte d'Ivoire. Vous avez la parole. Merci.
D'accord, merci Madame la Présidente. Nous avons déjà effectué ce type de prélèvement. Pour la lèpre, le bacille est intracellulaire obligatoire. Si vous prenez du liquide, vous n'aurez rien dedans. Le bacille est intracellulaire obligatoire. Lorsque vous faites le prélèvement, vous devez racler, avoir des cellules. Et ces cellules-là que vous mettez dans un petit tube avec une suspension de conservation. Mais si vous prenez le liquide, vous n'aurez pas de bacille. Nous l'avons expérimenté plusieurs fois. Merci.
Merci, Monsieur Kwaku, pour cette précision de savoir que le bacille pour la lèpre, il est intracellulaire. Donc, il ne s'agit pas de prélever la peau, il faut avoir des cellules pour qu'on puisse retrouver cette bactérie. Merci. Other question? Sinon, on va remercier Estelle avec des applaudissements. Thank you. Nous continuons avec le groupe 2 qui a travaillé sur la communication. Comment on va renforcer dans nos réseaux la communication. Donc, je demande à celle ou à celui qui est leur représentant de prendre aussi la place devant pour nous présenter les résultats de leur discussion. The moderator of the working group 2 communication, please.
All right. I'm sorry?
What?
Today, the communication group tried to focus on more avenues of communication. Yesterday, we focused on digital, website, social media, how to strengthen those and manage those. And today, we talked more about relationships that need communication strengthening. So one avenue we discussed is how to improve communication with national programs. And we agreed that we're very interested to hear what the group discussing programs has come up with, because communications would flow from those discussions. But we're excited about the possibility of collaborating with national programs on training for sample collection and facilitating those conversations, offering support, because of the complexity of all of your relationships with your national programs. Those are all different. They're all complicated, but we believe those conversations about sample collection training will be good for building trust and groundwork for future communication channels and building those in a better way and strengthen the reputation of the network as a whole. So that was one area we discussed. Another was how to give the network better visibility in the scientific community, whether that's in associations or at conferences, at meetings. We discussed the possibility of, within your national context, to find out if there is an association for tropical medicine or for laboratory science, whether that exists nationally, and if so, do you already have a presence there? Is that something that the network can build upon in the future? And we also talked about opportunities with regional or continental groups like the African Society of Laboratory Medicine, and making sure that we keep one another informed about those events and avenues, because those are great places to make presentations, to have a table, to make connections, and to give the network more visibility. We also, on a smaller scale, we talked about, with the transition to the new name for the Skin in TD's LabNet, and with the past 4 years of work that you've already done, this is a good opportunity, perhaps once we hire a communications manager, to create a video, a minute or less, but basically to tell people what the LabNet does in a very simple way, but something that would be useful for online communications and facilitating broader awareness of your work. And so to pursue that conversation, that will be a discussion about media facilities at different institutions, creating a script, like that might be something we do down the road, but it's really a good moment with the change to the new name to think about that as a branding project for the coming year, really. And in the middle of all of our conversations, we were getting very excited, and we realized everything we were excited about will need funding. And so we think that it's a good idea to consider hiring a fundraising officer who is pursuing opportunities for the network as a whole, because all of you are very busy being aware of opportunities for you and for your research and for your institution, and that's a whole job. So considering what would it look like to have a role that's dedicated to pursuing those opportunities for the network as a whole. So we've done a lot of work. In 2 days, we want to hire 2 new people. So those were our main conclusions from the group today. Thank you.
Thank you, Jessica. Now the floor is open for a question to the group. I see the first hand.
About the last part about hiring people, where will these people be situated? To which lab or where?
It made sense to us to think about them at being situated at the coordinating center at Centre Pasteur, but because both of those roles can technically work remotely and still report to the coordinating center, that could be open for discussion. It might even depend on which members of the leadership team feel like they have the capacity for a hiring search, and that even knowing who feels most comfortable with that might determine the best place to put out a search for someone.
Yes, you have other hands. Valérie, you have the floor. Mm-hmm.
Okay. Thank you for the group too. So I didn't hear about the timeline for this improvement of communication. For example, I don't know, is it going to be performed during the 5 next year, or at the end of the first year we need to start seeing the differences?
Mm-hmm.
So what do you plan for to be able to have it?
To see any difference?
Yes, to see any difference. Thanks.
Yes, I like this question. I think we have so many ideas. I think in order to achieve, particularly some of the ideas today, some of our ideas from yesterday need to happen first. So I think for everything the communications group discussed, our first step is still to identify who we currently have available to assist us with communication endeavors. So the first step is still to identify a committee from member of communications personnel within member institutions who are able to assist the network with basic things like maintaining the website and establishing a consistent social media presence. Like, that's still the first priority. It's basic, but it needs to be addressed first. Then other things are going to happen simultaneously with proposals from the other committees. So as the plan for going forward with national programs becomes clearer and comes into place, and as those relationships strengthen, then conversations about communication with national programs can also take better shape, because it is hard to make a plan when the specifics aren't clear yet. And then some things, like creating a video, you really don't want to do unless you have hired someone whose job it is to manage all of that chaos. Because it's a lot of work to produce something like that, and you don't want to put that much work on someone who already has lots of things they're doing. So there are some things that are actionable in the next 2 months, like identifying people to help, that we can do right away. And there are other ideas that it's like, maybe in the next year we can do, or maybe in the next year they will be clearer. But in general, I would say everything that we discussed is between 1 to 2 years in total, depending on how quickly a person can be hired, or how quickly it becomes clear that that's not possible, and you need to sustain a different plan for communication. So I would say all the ideas are 1 to 2 years, but it depends on the first things, how feasible they are.
Let me help you.
Dr.
Thank you very much for good ideas. I think really, really good ideas for communication. But I think we will plan through our advocacy, through different funds, through different funders, and we will see how we can implement it progressively according to what we can have. But really good ideas, and thank you.
Jessica? Now the last group, how we can collaborate with national program. Dr. Barogui.
Thank you. So I put the slide in English, so I will speak French. So c'est le troisième groupe, comme vous le savez, on en a parlé ici. Si le laboratoire, les réactifs et que les SOP sont bien installés comme décrit et qu'on n'a pas les échantillons, ça fait un blocus, d'où l'importance de cet aspect qui ne dépend pas seulement de l'équipe du laboratoire, évidemment. Donc, nous avons discuté certains aspects. Nous avons relevé 2 grands défis. Le premier, c'est la collecte des échantillons, et le second défi, c'est le transport des échantillons. Alors, pour le transport, les insuffisances que nous avons relevées dans notre groupe, c'est premièrement que le laboratoire n'est pas suffisamment inclus dans certains projets, dans la mise en œuvre du programme. Donc, nous avons proposé que le laboratoire soit inclus dès le départ dans l'élaboration de n'importe quel projet, de façon à être sûr que les différents aspects du labo sont bien pris en compte, notamment le renforcement de capacités, les réactifs, le matériel, la maintenance, etc. Deuxièmement, il faut s'assurer de l'implication. Il faut une réunion périodique pour faire le feedback entre le programme et l'équipe du laboratoire. Maintenant, au-delà de tout ça, il y a des aspects d'ordre général, notamment le renforcement des recherches de cas actifs que le programme doit pouvoir renforcer à tous les niveaux. Il est apparu que dans certains pays, les interventions sont limitées seulement à certains districts supportés par les partenaires. Donc, il est important que les chefs de programme arrivent à faire une mise à l'échelle des interventions au-delà des districts ciblés par les partenaires, décentraliser aussi la collecte des échantillons, et évidemment, il faut le renforcement de capacité des agents au niveau périphérique. Et ce processus, il ne s'agit pas de former une fois et laisser, ça doit être un processus continu. Et dans le contexte des pays africains, vous savez, le personnel bouge beaucoup. Donc, quand on forme un personnel aujourd'hui, un mois après, le personnel bouge. Donc, il faut que ce processus soit continu. Alors, pour le transport des échantillons, nous avons eu à partager l'expérience de la Côte d'Ivoire. Pour la Côte d'Ivoire, les échantillons sont collectés au niveau périphérique. Après, c'est envoyé au niveau national. Le niveau national est chargé de transférer ça au laboratoire. Ça, c'est un peu ce qui se fait en Côte d'Ivoire. D'autres pays peuvent partager d'autres expériences. Nous avons aussi pensé qu'il y a des programmes qui marchent bien. Par exemple, quand vous prenez le programme de polio, le programme de tuberculose, ils ont un réseau de transport d'échantillons assez développé, et il a été suggéré de voir dans quelle mesure les programmes nationaux de lutte contre les skin disease peuvent collaborer avec ces centres et pourquoi pas suivre le même circuit ou même faire des regroupements d'échantillons pour que le même agent qui envoie les échantillons de TB puisse faire aussi les échantillons de skin disease, même chose pour le laboratoire. Voilà un peu ce que nous avons dit, c'est un peu le circuit proposé par la Côte d'Ivoire. Merci.
Merci, Dr. Barogi. We have now the time for some question, 2, 3. Doctor, yes.
I think you forgot to add the programs, program management to be inserted into the panel of experts level so that we can have discussions right from the onset at that level. Thank you.
Dr. Sarah.
I would like also to insist in the first point when you mentioned that we have to include the program lab aspect. So the idea was more focus on donors so that when they are coming in the country, even if they would like to fund labs, they have to call program. Even they have to support program, they have to call lab. All these people have to be on the same table when we are planning for the project, not at the end, because generally funders come, discuss with program, finalize, and they just call the lab to say, you have to receive samples. And sometimes donor come, discuss on the lab to go on the field, and it's only at the end they are calling a program. So all those people have to be seated in the same table when we are drafting program.
Merci, Dr. Sarah. Yes. Valerie again, yes.
So, in addition to Dr. Sarah, I want to say that it is to the program manager as well as the laboratory manager to be sensitized on this aspect, because when the funder will come, they will come to meet one of them, and then if they are not sensitized on the fact that they have to be on the same table, so if the funder come and start with the program should know that I should call the lab before we start any discussion in the same way. And then my question for the group 2, thank you for the different proposition for this to be able to strengthen this collaboration between the laboratory and national program. So have you tried to identify the person who will be in charge to follow this? For example, the person at the level of the WHO in the country, to be able to follow this collaboration, to be ensure that those people, they are really sitting together to discuss. Otherwise, we will live here, and then if there is not a designated person or appointed person to be able to follow it, we don't know how they are going to be able to be together. Thank you.
It will be WHO.
Well, I hope that these points are captured in the meeting recommendations, which will be shared with also all program managers as well. As I said, all program managers are on the BU-LABNET platform, just to ensure that there is no disconnect between what we discuss on lab aspects and what the programs are supposed to do. Whether they follow the platform, I don't know, but we will share with them. I think the other point that Sarah mentioned, which I would like to emphasize, is the point number 1, whichever way the lab or the national program should be involved, right from the beginning. Even if it's a research project, and you know that you need the health service involvement in patient identification, collection of samples, etc., the national program managers should be involved. On the other hand, if it is a control project and there's going to be a lab component, the national program, the labs should be also involved right from the beginning. So this is, I think, this message we have to emphasize and make it clear. You don't finish your project proposal and then call the person, either the lab or the national program, that we have this project and we want you to be part of it. No, I think it's the wrong way of collaboration. So let's also try to address that.
Sort of concrete proposal. For example, this meeting is sort of 2 days long, mostly around the lab side, and then today we are having some scientific presentations. I would suggest that the meeting should have a day attached to it, which specifically is the interface between the programs and the labs, right? So the first 2 days, of course, can be on very technical aspects about how the assays are running, what is harmonized, how are the EQA procedures. Of course, the program managers do not need to come and sit and hear how well Sarah is at pipetting, but as has come up over and over, we do not have the right people in the room to discuss a lot of the other implementation challenges, and this meeting already brings together a good group of stakeholders. And I think if you had, a specific day before or after the lab-focused days that was on the integration across the lab program space, that would be good. And I think that is fundamentally different from hoping that everyone is on an excellent BU-LABNET emailing list or WhatsApp. Of course, people are trying to engage with that, but it is very different having people in a room. So I would really strongly recommend that in the next iteration of this meeting, a concrete action is to bring program managers to at least one specific day, and that way, when we're doing the lab talk, we don't have to talk about the program stuff. We can just move it all to one day. We can have 2 clean days talking about lab science, and we can have a clear day where we address the program link. That would be my recommendation.
Thank you, Dr. Michael. Other question? Comment? Positive comment? No comment. Donc, nous allons applaudir Dr. Barogui.
Applaudis. Et Teams.
We are moving now to the research session with presentation of Professor Richard Phillips, Estelle Serge, Emma, Richard, and Professor Doudou. Oui. And we have 10 minutes for all presentation. Only 10 minutes. By presentation, of course. Donc, Professeur Richard, présentation introductive, point sur la recherche sur les MTN cutanés, défis, opportunités. Moi, j'ai en tout cas en français. Introduction talk, update on research in skin entities, challenge and opportunities. Professor Richard, you have the floor.
All right, thank you, Professor Chair, for the kind introduction. So I'm expected to provide an update on research in skin NTDs, challenges and opportunities. Challenges and opportunities. My thinking is that there is a lot of expectation on BU-LABNET, and as we discuss the lab things, we need to put everything also into perspective. Looking at what the global world is expecting from BU-LABNet, because we've taken a big assignment on ourselves. Now we say skin NTD, so now it's even bigger. So most of the expectations, they'll be looking at us because they know that the tools that are needed are likely to come from us. So it's a sort of reflection that we are going to go through, and just to keep our thoughts straight, knowing that it's to serve as a reminder that there is a lot of expectation. And I bring you greetings from KCCR. When we started the planning, the plan was that we will end up in Kumasi, but it did not happen. So greetings from KCCR, the Garden City in Kumasi. Next time when you come to Ghana, we'll give you the opportunity to visit the campus. We also have a beautiful campus, and just like University of Ghana, very big campus, and maybe next time you get a chance to see our lab as well. That's our lab. So skin NTDs, we all know, is a huge burden, and already Kingsley showed this table, and different people have shown it, looking at the main skin NTDs that we need to be thinking about, and thinking about diagnostics. In 2021, we put out this paper trying to look at a comprehensive research and development plan to control, to support control, elimination, and eradication of neglected tropical diseases. And we recognize that research is highly needed to achieve the 2030 NTD roadmap targets. And during elimination phases, I mean, you need a lot of diagnosis play a key role in all this. You need sensitive tools, especially when you get to a point where you have few cases, and you need specific tools so that you don't deal with false positive diagnostic tools. And so a comprehensive research and development blueprint is needed to address the challenges that are expected. And there have been different publications trying to come up with or curate research priorities for the individual diseases. There are a number of publications that have been out picking individual diseases, bringing out the challenges, the key research questions, what people should be focusing on. And yeah, so my initial slides will look at some of the key topics globally that we need to be thinking about, and BU-Lab, Skin NTD LabNet, we need to situate ourselves within it so that we can together meet the targets that are expected. So I picked the diseases one by one to look at the key challenges and the issues that we need to be thinking about. If you pick yours, there are key global questions, geographical extent and evidence in the population, drug resistance emerging after MDA is a key question, best mobilization approach for eradication, effort of community mass treatment on yours, like lesions, like H2 Cray infection, and how many rounds of MDA do you need? When you pick Buruli, we are concentrating on development of point of care assays. I mean, we are not quite there, we are moving there, but point of care assays should be on our mind. New improved drug regimen, it's top on BU list. When you pick leprosy, a lot of things that we need to think about. PCR on confirmatory diagnostic tools for leprosy, preferably at the point of care. Antimicrobial resistance surveillance in leprosy is key. Diagnostic tools for screening for M-leprosy infection in contacts of leprosy cases, tools to ascertain transmission in endemic communities. They are key questions. And bedaquiline and telosebec repositioning trials as these new drugs come on board. And for onco-safe and effective macrofilariasis sites and lymphatic filariasis, the same, looking at pharmacological therapy that reverse lymphatic dilatation and improve lymphedema. When you pick scabies, there are a number of hot topics: validation of the IACS diagnostic criteria, data on ivermectin MDA in varying settings, including non-island populations or settings, optimum implementation of MDA, including the threshold for intervention, dosing and the frequency, monitoring and evaluating of control strategies by programs, and population data we know is lacking. We need more population data. These are all challenges. When you pick cutaneous leishmaniasis, we have the optimal diagnostic tools and better treatment. They are all hot on the list. Post-Kala-Azar, new improved treatment. Mycetoma, new improved treatment, new diagnostic tools. Candidiasis, new drugs. These are all issues, global research issues that we need to be thinking about as we try to put our act together to get skin NTD diagnostics going. In 2001, just when COVID was on, we had a little meeting in Kumasi to set operational research agenda for skin NTDs in Ghana, and I see many familiar faces. We brought together stakeholders from the national programs, from the ministries, and from the communities. We have village volunteers that joined to try to in a 2-day workshop, set up operational research plans that are culturally sensitive, context specific, and beneficial to the communities of interest. Because in looking at the global, you also have to think about your communities. What is globally, what is locally, culturally sensitive and context specific. And we thought it was good that we come together to try to think through the different areas of research and the challenges that face skin NTDs in particular. And we looked at four main thematic areas: disease transmission, surveillance and reporting, epidemiology, modeling, mapping, technology, and innovations, and then diagnostics, laboratory case definitions, case detection, role of community-based surveillance workers for skin NTDs, and then there was another thematic group for case management, treatment, wound care, disease prevention, and then there was the group dealing with social, economic stigma and discrimination, disability, mental health, social, anthropological, and health systems. So we had these four thematic areas to try to think about what are the key challenges and what are the main research topics, the priorities, country specific, what are the key priorities. And I'm not going to share all that came out of that, but I'm picking out the diagnostics area, that I think concerns us. So we try to think through diagnostics. That was the theme 2, diagnostics, looking at laboratory confirmation, case detection, role of CBSVs for skin NTDs. And we had vibrant discussions, throwing ideas left and right, and we came up with some priorities somehow. And priority 1, the group thought, was research into synergistic roles of CBSVs and the health system for early case detection of skin NTDs. That it was research that had to be carried out because they do play a key role in that the case detection system. And priority 2 is research into development of rapid diagnostic tools for case confirmation, and we are going to hear quite a lot of research in that area because it's still a priority, the group thought. And 3, research into multiplexing diagnostics, assays and tools for integrated NTD case detection. There's been a lot of talk about multiplexing, and it was still on their mind. Multiplexing is key priority. If we're able to do it, all the better for us. And research into diagnostic tools for detecting and monitoring drug resistance in skin NTDs. And yes, we've been talking about leprosy resistance and also in yours. I mean, those are all still big priorities for diagnostics. And operational research into sample collection, handling, and transportation. Working out some of those things locally, nationally, can be very complicated, and you need research to try to understand what works best at the country level, at the local level, because each country will have its own issues, and you need to understand what works best in the Ghana context, what works best in the Cameroon context, etc. Because that is what, if you have the two and that system is not working, you will see deficiencies in the system. And priority 6 was research into different sample matrices and sampling techniques for the skin NTDs. And 7, research into innovative techniques such as mobile technology to enhance case detection and diagnosis. Mobile technology was 7. And 8, evaluating existing diagnostic tools for skin NTDs, looking at different parameters, including ease of use, the cost for optimal uptake. And 7, evaluating the patient referral system, because we thought sometimes using the referral system, patients get lost, they don't end up being found to be diagnosed. So these were the priorities that the group came up with, and there are some of the ideas that in other countries will also apply, but locally those were the thoughts that the group came. And we looked at opportunities. What were the opportunities to do things differently? We looked at opportunities to do things differently because we've been doing things in a particular way for a long time. And one main thing was integration, and we all know about that. And that's what we're also trying to do, moving from silos to integration. We thought was a key opportunity for us to get into. And also data sharing, periodic data analysis, sharing to monitor integrated efforts for case detection and confirmation of skin NTD, because we need to be moving data across so that everyone knows where we are at each time, and evaluating our actions, especially our SOPs. Are they working? Assessing the impact of our efforts in case detection and diagnosis of skin NTDs is key. And then also looking at CBSVs, they can be really effective in supporting surveillance activities to achieve targets. So to explore ways of keeping them motivated, such as regular training and retraining to equip them. And then also, if we looked at effective collaboration between policymakers, researchers, and the community, and that the engagement should keep on going. And following that discussion, we thought that, okay, if we have to keep research moving, we need to look at what are the opportunities to attract resources that are needed to keep things going. What are the opportunities? So we came up with different things. Resources could be of national origin, from national governments. Local government budgets, they do have budgets that potentially could go, some of it could go into research. And also lobbying parliamentary select committees to increase the budgets and skin NTDs.
1 minute.
Yes, I will. That's my last slide here. And then also taxes on products that affect health. So tax origin. So money coming from government. I'm sure most of you will say that we've not seen a lot of money coming from government, but it's a potential source for money. And looking at African or Ghanaian philanthropists, I'm sure in our countries we have really people that are philanthropists that could also support the program. Engaging companies and industries to contribute as part of corporate social responsibilities. and improving the efficiency in what we do so that we can use our money efficiently is another way of making sure that there is money in our hands. So if we are doing things the wrong way, we need to change the way we do it so that we'll have enough money to keep research going. And then the last one being international funding agencies. But overall, we think that research is central to achieving the 2030 NTD roadmap targets. But we need to keep reviewing what we are doing because there is a lot of expectation on the research world and the scientific world, and there will be a lot of expectation from SKIN, NTD, LABNet. And we need to keep our focus because the world's eyes will be on us and they will expect the diagnostic tools from us. Thank you very much.
Thank you, Professor Richards. We have now 2 minutes for question. I think all things very well clear. Yeah.
Valerie.
Dr. Valerie.
Okay. Thank you very much for your presentation. So I just want to clarify about the 2 days of workshop. So I wish to know if it is only during those 2 days you have been able to prepare all the plan that you were showing to us.
Well, a lot of it was done in 2 days, but there was pre-engagement before the 2 days. We had questionnaires going out, but I didn't go into all that detail. But it all culminated in the 2-day meeting when we brought everything together. Yeah.
Question. So how is your feeling now after this plan that you have been prepared before? So at the level of today, are you feeling that there are some things that is moving from this that are...
Well, I think the key thing is that it gives us a clear idea of if we have money or if there's funding, where should we put our money first? Because at least you should have your shopping list. If you don't have a shopping list and you don't know what is the real priority, then when somebody brings money, oh, what do you think is the topic you need to deal with? You could go for the bottom topic, but the priority ones will be there. So it's good for us to keep our focus so that once you have a priority list, it helps you know what you are dealing with. And I think there are some of the topics that I already see that in the presentations that are following on, like multiplexing, there are groups dealing with it, but it's supposed to keep us knowing whether we are ticking all the boxes. What are the areas that have not been dealt with? And that is the rationale behind it. Yeah.
2 questions, Michael Marks and Dr. Lydia. First, Michael.
I guess mine is a comment mostly. I think it is extremely useful to have these types of prioritization exercises published because when you are writing a grant application, being able to reference that the application you are putting in is responding to a pre-identified priority with an appropriate group. So I know that whenever I write an application on yours or on scabies, I always reference, you know, either the papers that we put out with WHO, which say, here are the 10 questions. So that's the first thing. I think thinking about, can this process be redone across the whole LabNet and result in, you know, a good paper in a good journal, which can also then be reinforced. The second thing is just to be realistic that, you know, the thing that mostly determines what we get research money for are what the funders define the questions as. So, for example, this year EDCTP have a call on point-of-care diagnostics, so it makes sense for the LabNet to put in an application focused on that bit. If next year the call from EDCTP is focused in a different bit, there will still be a skin NTD question to be asked. So it's sort of 2 pieces, having that priority list published so it can be referenced, and having some ready-made ideas based off that list so that when a call comes, you can say, okay, for this call, questions 2 and 3 from the priority list can be addressed for this funder.
Thank you, Michael. We can give now. Lydia, your question is okay now?
So my question is, I noticed that transmission is not really high on the agenda for Bruglia. Is there why? I don't know. I just wanted to ask that.
Lydia, I did not prevent the transmission track of the priority list. I decided to concentrate on diagnosis because of our current setting, but there's a whole shopping list on the transmission.
Professor Philippe, thank you for the presentation. We are calling now Estelle for the second. Sorry. Dr Estelle va présenter sur les perspectives de l'épidémiologie moléculaire dans la compréhension de l'écologie et du mode de transmission de M-ulcérance. Vous avez 10 minutes.
Je vais parler en français. Pour vous présenter donc une étude en cours dans l'équipe et aujourd'hui je voudrais vous présenter les apports de la génomique comparative et l'apport des sciences humaines et sociales pour essayer de comprendre la dissémination de Mycobacterium ulcerans. Donc on a réalisé une phylogénie de Mycobacterium ulcerans en utilisant toutes les séquences disponibles sur NCBI. Donc on a environ 1000 séquences accessibles et vous voyez qu'on peut, sur cet arbre, différencier 7 profils, donc de P1 à P7, qui en fait sont très liés à l'origine géographique des patients, qu'on voit mieux sur cette carte. Donc on a en Australie le profil qu'on appelle P1 et ensuite dans tous les pays autour du golfe de Guinée, différents profils qui sont très liés à l'origine géographique. Et donc on voit par exemple au Cameroun 2 aires endémiques bien distinctes donc autour du Nyong et à Bankim au niveau du barrage et ces 2 profils bien distincts et il n'y a pas eu de mélange entre ces 2 profils. Donc si on regarde l'origine des souches dans ces 1000 séquences, on voit qu'il y a des pays qui sont bien représentés et des pays qui sont moins bien représentés. Et vous verrez l'importance en fait d'essayer de représenter l'ensemble des zones endémiques pour pouvoir mieux comprendre la dissémination d'ulcérance à travers le temps et l'espace. Donc ici, on va passer à une échelle beaucoup plus petite où on a travaillé à l'est du Bénin sur la rivière qu'on appelle Ouémé. Donc dans cette toute petite région, on a la chance d'avoir accès à plus de 300 séquences de Mycobacterium ulcerans isolées de patients. Et donc, on est capable, dans cette toute petite région, de différencier 8 sous-populations qu'on appelle des génotypes, 8 génotypes différents qui circulent dans cette petite aire géographique. Donc on voit par exemple que le génotype 8 en bleu, mon pointeur ne marche pas. Le génotype 8, c'est celui qui est le plus présent, mais on a aussi 7 autres génotypes qui circulent dans cette petite aire géographique Et c'est des souches qui ont été isolées de 2006 à 2020. Alors en fait, la première question, c'était de savoir si ces génotypes, ces 8 génotypes, on les trouvait indifféremment partout dans cette aire géographique. Et en fait, on voit que non, qu'il n'y a pas une distribution aléatoire de tous ces génotypes. Donc l'exemple le plus facile, c'est par exemple le génotype 7 en rouge. On le trouve quasiment exclusivement dans le sud du Ouémé et pas dans le nord du Ouémé, alors qu'il y a quelques kilomètres entre les deux aires géographiques. Donc au sein même du génotype 8, qui est le plus représenté, on arrive à faire des sous-groupes dans ce génotype. Et même ces sous-groupes dans le génotype 8, ils ne sont pas du tout aléatoirement dispersés. L'exemple le plus concret, c'est le génotype G, qu'on trouve exclusivement dans le sud du Ouémé. Donc tout ça, ça suggère qu'il y a des réservoirs non mobiles dans ces aires géographiques. Alors comme on arrive à avoir beaucoup de souches, on est aussi capable de dater l'introduction de ces souches dans cette aire géographique. Et alors, je ne vais pas tout détailler, mais donc le génotype 7 et 8 qu'on retrouve le plus souvent dans le Ouémé, en fait, il a été introduit très récemment, à la fin des années 70. Et en fait, les autres souches qui circulent, et les plus anciennes, le 1, le 2, le 3 et le 4, sont liées à des souches qui proviennent de patients qui habitent au Nigeria et qui viennent se faire traiter de l'autre côté de la frontière à Pobé. Donc ensuite, on a voulu aller plus loin et on a décidé de travailler avec des chercheurs en géographie de la santé, donc qui viennent des sciences humaines et sociales. Donc ils n'ont pas du tout la même méthode de travail que nous, mais on les a embarqués dans ce projet en leur présentant cette situation que dans le sud du Ouémé, on a un génotype 7 et 8.G qui circulent quasiment exclusivement dans une toute petite aire géographique. Ça c'est possible puisqu'en fait, dans cette zone, l'hôpital de Pobé réalise une surveillance active depuis plus de 10 ans. Et donc, on a une très bonne idée de l'épidémiologie de l'ulcère de Burgdorf dans tous ces villages. Donc on a eu un financement qui a permis de tester une méthode qu'on appelle une méthode d'enquête géographique de santé, qui consiste à aller chez le patient ou l'ancien patient et à collecter toutes les informations qui concernent ses activités. Toutes ces activités. Donc après, c'est adapté suivant si c'est un enfant ou un adulte. Donc activités liées à l'eau ou pas liées à l'eau. Et en fait, cette interview, elle est ensuite complétée par ce qu'on appelle des enquêtes commentées. Donc en fait, on va avec le patient dans tous les sites qu'il a pu évoquer lors de son entretien. Donc ce qui permet de voir et de prendre des photos et des coordonnées GPS en fait, de son buffer de vie, qui peut être plus ou moins grand suivant ses activités. Donc en fait, on a appliqué cette méthode à 33 patients qui étaient soit contaminés par le génotype 7, soit le 8.G, soit par un autre génotype qu'on peut aussi retrouver au sud Ouémé. Et en fait, on a réalisé cette enquête à l'aveugle. Ça veut dire que ceux qui interrogeaient les patients et les suivaient dans leurs activités, ils ne savaient pas si le patient il avait été infecté par le 7, le 8 ou un autre. Donc, on a fait ça à l'aveugle pour limiter le biais qu'il y avoir. Donc là, c'est vraiment une étude qui est en cours. Donc là, sur 17 patients, vous pouvez voir les buffers d'activité de tous les patients sur cette carte. Et donc, on a mis tous les coordonnées GPS des lieux où les patients avaient une activité. Et donc, on se rend compte rapidement qu'on a identifié 3 zones, dont la plus grande ici, qui regroupe beaucoup de patients avec des activités, alors qui peuvent être différentes, mais qui ont le même lieu. Donc ça nous permet d'émettre des hypothèses. Ensuite, on a le résultat sur le génotype 8, alors qui, de base, en épidémiologie, est très intéressant, puisqu'en fait, on a une distorsion du sexe inverse d'habitude. Donc là, en fait, le génotype 8.G, il touche que les jeunes filles, alors que dans la population globale de patients ulcères de Buruli, c'est plutôt les jeunes garçons qui sont surreprésentés, et c'est les filles adultes qui sont ensuite plus représentées. Donc là, curieusement, le 8.G affecte et cible les petites filles. Donc ensuite, lorsqu'on regarde les aires d'activité de leurs activités, on a aussi isolé 3 aires géographiques. Et en fait, dans ces aires géographiques, il y a beaucoup d'enfants et de petites filles qui pratiquent différentes activités. Donc si après on superpose les 2 cartes pour le génotype 7 et 8.G, on voit que les 2 principales zones ne se superposent pas du tout, même si on est à une toute petite échelle. Donc évidemment, après, le but, c'est d'essayer d'élargir cette étude à d'autres patients. Là, vous voyez aussi en jaune les habitudes des patients qui étaient contrôles, qui n'étaient ni 7 ni 8.G, donc qui ne fréquentent pas du tout les mêmes lieux. Et donc, on espère aussi pouvoir appliquer cette méthode aux autres génotypes. Donc voilà, juste après, je pense que du coup, maintenant, vous avez tous des laboratoires qui permettent la confirmation par qPCR de l'ulcère de Buruli. Donc vous pouvez constituer une biobank, une biobanque d'ADN positif ou d'extraits positifs. Il y a même certains labos qui ont la capacité d'isoler Mycobacterium ulcerans sur milieu Lowenstein-Jensen. Et donc, on pourrait tout à fait imaginer, comme Michael l'a dit, si un jour il y a un projet scientifique porté sur l'épidémiologie et les études génomiques, tout à fait envisager de répondre à cet appel d'offres avec certains laboratoires qui seraient intéressés et qui ont ces biobanks disponibles ou qui vont le créer, quoi. Voilà, je vous remercie.
Merci Estelle, merci pour la brillante présentation. Nous passons aux questions. Some questions. Big project. Commentaires, comment. Oui, Dr. Anthony.
Thank you, Estelle, for sharing your data on the distribution of Emotrans whole sequence data. Some years ago, we did a similar work in the Agugu area. And then I'm just happy that the results you had basically lends credence to what we also had some years ago. 2 basic things. That's one, Emotrans, we found that Emotrans can be imported from another place into a new area. That's one. And then the second one is that the genotypes of a specific strain will reflect the fact that when Emotrans maybe is transferred to a new place, it remains the dominant genotype there for a long time to come, and through the years, it gradually accumulates mutations. That makes it a specific genotype for that specific region. You see, so I'm glad that at least we've had whole sequence data that also confirms our findings some years back. Thank you.
Thank you, Dr. Anthony. Or comment? Yes.
Hello, Estelle. Thanks once again. I have a brief question. My question is, did you compare the genotypes that you had with any clinical presentation, whether some particular genotypes sort of presented with either bad diseases or severe disease forms, or even different clinical presentations?
Yes, we did it, and there is no relationships between genotypes and severe form or osteomyelitis form, for example, for the age of patient or sex. We have no difference.
Thank you very much for this nice, elegant, well-designed study. We did a similar study in mycetoma to find in the environment some of the genotypes of the causative organisms. And we compared that with the culture method. And we find the culture method, most of these organisms were not grown in the culture method. So did you find the same finding in your study, or you did not compare the culture method with the genotyping studies at this site?
So here we worked on isolate from human samples. So we didn't look at the presence of Mycobacterium multiresistance in environmental samples. We're trying to do it. So after that we can try to compare genotype present in environment compared to human. And I didn't get your, you compare the cultures and directly on the sample of the patient? Yeah. On the soil. Yeah, so for us, we are just able to detect Mycobacterium multiresistance by qPCR in some environmental samples, like plants, aquatic insects, but we are not able to isolate strain from environment. So it's quite difficult to compare genotypes that are circulating in environment compared to human.
Other comment? We thank Esther for the presentation. And we call now the last speaker, Dr. Serge. Overview on skin entities in yours. Endemic region in Cameroon, Côte d'Ivoire, and Ghana. You have the floor, Doctor. Ten minutes.
Thank you for giving me this opportunity to present a work which falls within the roadmap of the WHO 2021-2022. I'm presenting on behalf of the Lamb for Yours project. Yours is endemic in most sub-Saharan Africa region and South Pacific, and most data reported to WHO are based on passive surveillance, which are not, which do not reflect real data in the field. Active case searching in the field offer the way to report real data for particular skin disease in the field. And the integrated approach of the WHO is also a way to report other skin condition during maybe specific or vertical surveillance of a particular diseases. The objective of JIP study was to describe the skin condition arising from active case searching in health district known to be endemic for use in Cameroon, Cote d'Ivoire, and Ghana. And during this activity, we look for. Sorry, there is a problem with my. Okay. So. Yes, we try to identify the skin diseases in the selected endemic district for yours and other skin condition encountered. Our study was performed in 12 health districts in Cameroon we were reported to be endemic to yours in 6 districts in Cote d'Ivoire and 7 in Ghana. The activities include examination of all participants in the selected rural community, mainly for yours, which was the first disease of interest, and follow examination with the test with the RDT to confirm active yours or patient without yours. What I can mention here is that other disease conditions were just recorded and reported to the health facility in the community for routine care. And our activity, the active case searching, was done in schools, in health center, during MDA, and by house to house, mostly in community where people were not enough. The result of the active case searching in the 3 countries revealed that we screened around 61,000 people in rural community, in selected rural community, 20,000 in Cameroon, 16,000 in Cote d'Ivoire, and around 24,000 in Ghana. Most and skill lesion accounted around 20% of all screen participants, with around 20% of skin lesion in Cameroon, 30% of skin lesion in Cote d'Ivoire, and around 10% of skin lesion among participants in Cote d'Ivoire. We recorded yours as the GPP positive in 8% of participants in Cameroon with yours like lesion. 6% also, around 6% in Cote d'Ivoire among participants with yours like lesion, and 26% among participants in Ghana with yours like lesion. Other skin condition or skin entities include leprosy detected in Cameroon and Cote d'Ivoire, scabies most detected in Cote d'Ivoire with thousands of scabies, and we reported also lymphatic filariasis in Cameroon, more in Cote d'Ivoire, and this was rare in Ghana, maybe due to the target population. And we recorded also borreliose in Cameroon and Cote d'Ivoire. I have just to mention that other skin entities reported here were based on clinical examination. Alongside the search of skin entities. We also reported other skin conditions, mainly fungal superficial infection, including tinea corporis, psoriasis, and tinea capitis. Cameroon recorded almost 60% of this fungal infection, Côte d'Ivoire 40%, but in Ghana we recorded something like less than 1%. This due to the fact that due to the amount, the degree of activity focused on yours, this was not in routine reported in the sheet within, because we know that in some remote area we encounter some participants with those fungal infection. These are some pictures took during the active case searching, mainly for Yos-like lesion, borrelia, scabies, lymphatic filariasis, lymphedema, leprosy, and for fungal infection, we recorded this psoriasis, tinea corporis, tinea capitis, and we saw this kind of lesion during active case searching, but we did not know what, but we took picture to keep. Maybe for next investigation we will need some expert in dermatology to assist us interpreting those skin lesions, mainly with artificial intelligence, which is ongoing in many programs. This will be a step forward for the fight against skin entities or other skin conditions. The main challenge we encountered during the active case searching was the difficulty to access some community where yours is endemic, mainly in Pygmy in Cameroon, Baka population. We are population, we live in forests and live sometimes to one forest to another, and it's difficult to follow them. And also inter-community movement. Across the 3 countries, we encounter this problem, and also resource to manage the affected population. But it's very difficult to leave maybe a child in a community when you come only with a specific resource to manage a disease. And we have yours with the treatment, but for other skin conditions, we refer to the health center, and we know the reality in the context in Africa. To the end of this work, we can say that integrated screening allows simultaneous detection of multiple skin diseases. Through this active case searching, we reported superficial fungal infection, maximizing the use of the scarce result. This data on other skin conditions can also guide where effort can be taken when we want to address a specific diseases. As key home message, this study highlights how the use of existing disease-specific resources can be maximized to determine the burden of other entities. Integration.
1 minute.
Integration, technical and scientific progress are all pillars of the roadmap to end the suffering caused by skin entity by the 2013. We cannot end this work without acknowledge all participants and our founder, ADCP, through the Land for Yours project. I thank you very much.
Thank you, Dr. Serge, for the good presentation. Now, some question for the participant. Yes, Isra.
Serge.
Yeah.
Thanks very much for the presentation. Impressive work. So congratulations to you and your team. Just a couple of curiosities. Did you, maybe I didn't get it, did you find any Haemophilus Ukraine, or were you able to confirm any Haemophilus Ukraine?
Yes, we found many Haemophilus Ukraine and we confirmed it by qPCR.
Okay. And then you show the results by type of infections. Let's say, you talk about the skin lesions and type of infections or type of diseases. Do you have an estimate of if you separate them like by ulcers and other type of manifestations, like how many type of ulcers did you found, and whether you were able to confirm the cause in part of them, all of them?
Yeah, we have many kind of type of skin lesion. At least they were several traumatic lesion, also infection, ulcer due to infection. And what based on the booklets we have and the material training of national program, we were able to report what we learned, but we have to just mention that many of other skin lesions apart from skin entity maybe were misread. Yeah.
Serge, question, Dr. Professor Doudou.
Question. I'm curious, what did you do for the other patient when the skin neglected tropical diseases are not confirmed? Did you send them or refer them to a dermatologist, or did you just let them in the villages with some advice or something like this? I'm just asking myself.
Responding that leave patient with suffering is not ethical for me. We refer them in the health system, in the healthcare around the village. And for other skin entities mainly, like lymphatic filariasis, and I can take the case of Buruli ulcer, they are a national program who are in charge of to follow up and follow up treatment, everything. But for other, we just refer.
Dr. Barogi, at one question, I hope.
For this excellent work, I want to know what is the profile of the team that carry out this integrating activity on the field. For example, we saw that we have a lot of cases of leprosy in Cameroon and also in Côte d'Ivoire, but at the same time, no cases of leprosy have been found in Ghana. Is it the same team? Second thing, it is that most of activity have been carried out in the school. Leprosy in children, it is a key indicator for us. So, and also detect leprosy in children is not so easy. So I want to know exactly what is the profile of with this team who carry out this activity to detect some cases of leprosy in some country and no cases in another country. Thank you.
Okay, the research team were composed of a scientist, medical doctor, technician, lab technician, a nurse, and personnel of national NTG program.
There is no dermatologist in your study?
What? Can I clarify? Is that okay? This is an adjunctive project done alongside collecting diagnostic samples to validate an assay for yours. So deliberately, the sampling is designed to target children because 95% of cases of yours are in children. So you just have to bear that in mind, right? That this is like a bonus that we got alongside collecting samples. And there aren't dermatologists because there are not enough dermatologists, and certainly not one who is prepared to go off into the rainforests of Cameroon to track down the pygmy populations coming in and out of the forests. So it's not at all feasible to have dermatologists in the field for 2 or 3 months. It's simply not possible.
Okay. Yes. And info?
Yes, thank you. There is a question online for Serge from Christian. He's asking if you saw examples of co-endemicity and for which diseases.
We found many co-endemicity for boreal ulcer, leprosy, and lymphatic filariasis with yours. And what I can mention here is that for the activity or to integrate molecular diagnostics of yours, we use data obtained through this study to collect actual sample we use to validate our test for the qPCR for leprosy. This guide us and to find a village where many cases were there without treatment, and these data were transferred to the national program, and all those patients are now under treatment.
Thank you. Merci. Other question? I think. Thank you to Dr. Serge. We are calling now in the floor Dr. Emma. Contribution du consortium BLS-BU, BU-LABNET. Two.
Thank you. It's okay. It's where I have more credit. Well, it's fine. It's fine. It's okay. Yeah, but it's okay. Yeah, thank you. Okay. So, well, good morning, and thank you for the opportunity of presenting the project here at BU-LABNET. So I'm going to present the contribution of the beta-lactams for BU consortium to BU-LABNET. So first, I would like to present you a bit to introduce the project. So it's the beta-lactam containing regimen for the shortening of boreal ulcer disease therapy. So the aim of the project is to assess whether BU treatment can be reduced from 8 to 4 weeks by co-administration of amoxicillin clavulanate with current rifampicin and clarithromycin therapy. So we are comparing the two treatments, the standard one, which is 8 weeks of rifampicin and clarithromycin, versus the 4 weeks, a 4 weeks treatment of rifampicin, clarithromycin, and amoxicillin clavulanate. So for that, we are conducting a clinical trial, a randomized control open label non-inferiority and multicenter. It started in Benin, the project, in December 2020, and 1 year after we started the clinical trial in other 3 countries, Togo, Ghana, and Cote d'Ivoire. So of the clinical trial, the primary efficacy outcome is the cure, which means the lesion healing without recurrence and without major excision surgery, 12 months after the start of treatment. And the population for the primary efficacy analysis is the PCR positive BU patients. So this is why it's very important for us, the diagnosis and the IS 2404 real-time standardization and quality control. In addition to that, there are, for the clinical trial in Benin, we have 2 secondary objectives. The first one is to test whether the treatment of 4 weeks could improve the median bacterial clearance rate over the standard treatment, and to investigate if this hypothetical increase in the median bacterial clearance rate correlates with a reduction in the median time to healing of the lesions. So for that, we are performing in a bacterial clearance study by a combined qPCR assay. So I'm going to present more these 2 components. So the first one is the standardization and quality control of PCR diagnostic. So for the clinical trial, it's very important the molecular diagnosis of BU cases. There are 4 laboratories who are in charge of the diagnosis for the clinical trial, who is the laboratory in POVE, in the Center of Screen and Treatment of Buruli ulcer, the laboratory at the Institut National d'Hygiène in Lomé in Togo, the KCCR here in Ghana, and the Institut Pasteur in Côte d'Ivoire. So for us it was very important to ensure the adherence to the SOPs developed by the BU-LABNET, and also to the harmonization with the procedures of the beta-lactam study. So for the quality control, we have 2 components. The first one is the external quality assurance. As you know, all these laboratories participate in the EQA organized by BU-LABNET, and also from last year also we started to participate. And in addition to that, we organize an internal quality assurance for the clinical trial. So we have 2 different panels that are sent in a blind way. Clinical samples that are sent from the laboratory in POVE to Ghana, Togo, and Côte d'Ivoire, and now the next round also we are going to enter in this, and also DNA samples that we sent from the University of Zaragoza to the other 4 countries. So we organize it before the start of recruitment of patients to know the diagnosis is good, and afterwards 6 months after recruitment, and annually from that. So as Benin started 1 year before than the other countries, there have been 2 rounds of quality controls there, in April last year and this year, and also in the other countries there have been 1 round up to date. So here we can see a bit the results. So as you can see in the 4 laboratories, there is an overall good performance and high accuracy was observed. However, there were a few things that could be improved. So here, for example, you can see that the percentage of false negatives among weak positives, it was a bit high in one of the laboratories. So we assumed that there was a low sensitivity a bit. So the measure that we decided to implement was to double the quantity of DNA template for the negative samples. Also, this laboratory had the same problem, but had also a slight amplification in the negative control. So after several tests to try to see what could be the problem, we decided to wait also for the next round of IQA that we are going to perform at the end of last year to see how it goes, and also to do at the same time the diagnostic in another laboratory. And finally, the turnaround time was excellent in all the laboratories, but one has to improve a bit because it was a bit late. So the next steps, as I mentioned, it's that the next round is going to be in November, December this year, and also to monitor if the implemented corrective measures have improved the results. So in addition to that, there is the bacterial clearance study. As I mentioned, the hypothesis is that the treatment of 4 weeks increased the median bacterial clearance rate, and this would reduce the median time to healing. So the aim of the study is to quantify the rate of bacterial clearance in the lesions during the course of therapy and to correlate it with the outcome of the treatment groups. So for that, we are going to quantify the bacterial load by a combined PCR, RNA, DNA. So this qPCR was developed in 2012, and also it was proven in a study in Ghana that it was very good for monitoring the drug treatment response. So we performed first an in vitro validation, afterwards we implemented it in POVE, and at the end we started the study last year. So for the in vitro validation, we performed it at the University of Zaragoza. We compared this methodology with the colony forming units counting, optical density, and also with luminescence, and we saw that all the methodologies had a very good correlation. So afterwards, we implemented this combined qPCR in POVE, and finally, when we had all ready, we started last year the study. So what we do is to take 3 samples for all the patients who consent in POVE to participate in the study at different time points, at the screening and also at weeks 1 to 8 and even 14, when the lesions are not healed. yet, and to quantify the bacterial load using this PCR. So up to date, there have been 54 patients who have been recruited, and samples from 29 patients have been processed. So, well, the main conclusion is that through the different activities, the Beta Lactams for BU Consortium contributes to the mission of BU-LABNET by strengthening the laboratory capacity of qPCR diagnosis in the region, and also by sharing knowledge and experiences between the member laboratories with the BU national programs. So I would like to acknowledge many people, also the whole consortium, but especially the people in the laboratories who are here and also who are not here but work at the laboratory also. To Lynn, who is a very key person on all the quality control and also the bacterial clearance study that she's performed. To Isra Cruz, because also he is coordinating the part of the standardization and quality control with me. And to Esther Marion, who is a part of the independent advisory board and who has advised us also in the quality control assurance. So thank you very much.
Merci Emma. Vous avez fait 9 minutes, donc on a encore le temps. Les questions? Question? Dr. Sarah is ready.
So thank you, Emma, for the presentation. But perhaps I missed a point. What are you sending to the lab as AQA? Is it DNA or samples?
From Benin, from Pobe, they are sending clinical samples. And from the University of Zaragoza, we are sending dried DNA samples.
Thank you. Other question? Yes, Dr. Valérie.
For your presentation, I have a question concerning the internal quality assessment. They are sending, as Dr. Sarah said, 2 different panels, blind panels. And those 2 panels are positive and negative?
What I mean is that we send 2 panels because they are different samples, but we send them, I send the DNA sample, so I mix positive and negative, the positive also with different quantity, strong positives, weak and medium positives, and also from Benin they send clinical samples, it's like the AQA that you perform, but we do another one within the laboratory of clinical trial. So we send usually, the last time it was 10 DNA samples, there were 5 or 6 positive for negative, and for the clinical samples the same.
Other question? Thank you, Emma, for this good presentation. We are moving now to Dr. Richard. Effort to improve the fluorescent thin layer chromatography method in the diagnostic of biliary ulcer. You have the floor, doctor. 10 minutes.
Good afternoon. I'm Gideon Akogo. I'm presenting this on behalf of my boss, Dr. Richard Ameu. So we're basically providing a report on the efforts to improve the fluorescent thin layer chromatography method for the diagnosis of BU. At the onset, I would want to indicate that we are not using the PCR technique, even though our work relies heavily on PCR, because we are doing a comparative study
and we can't work without the PCR reference laboratories. And yesterday, at the recommendation to take off the DNA strands from the logo was actually exciting to some of us, because we don't work directly with the DNA, but the toxin that is produced by the mycobacterium. Yes, so diagnostics is key to what we are doing here today, because without diagnostics, medicine is blind. And we are keen on diagnostics because of the effectiveness of these antibiotics treatment for particularly Brule ulcer. And ever since the introduction of antibiotics, I know our focus generally has been on diagnostics. But again, we all can attest to the challenges that we face with the standard diagnostic methods that we use. And there is therefore a need for a tool that meets the assured criteria largely, now reassured, in terms of affordability, sensitivity, specificity, being user-friendly, all the way to being delivered to those who actually need it, considering that we are dealing with neglected tropical diseases. So our aim is to target the mycolacton. The mycolacton, because unlike M. tuberculosis and leprosy, ulcerans produces this toxin, which is very unique in the human pathogen. Was initially isolated in 1999 by George and co-workers, and has shown cytotoxicity and immunosuppressive properties. Subsequently, the gross structure was confirmed and its absolute configuration. And we are much more keen on the configuration and the chemistry of this toxin, because it is unique in the sense that it has a structure that is amenable to detection, because it has what we call the OH groups along this chain, and also this, which we actually take advantage of for detection. But more so because the toxin is also evenly distributed in infected areas. So our belief is that detection of mycolacton still remains a front runner towards developing a rapid diagnostic tool. Now, our work actually follows the discovery of the method by the late professor of chemistry in Harvard, Prof. Kishi, who's done a lot of work on mycolacton. And subsequently, the method was evaluated on a few clinical samples with promising results. So what we were mandated to do was to evaluate this method across endemic communities along the region. And since 2014, we've done this, set up centers and evaluated the technique in the larger clinical samples. The chemistry is not what you should focus much on, but just to say that basically what we do is to use the boronic acid as a stain, and then the boronic acid, what it does is to provide fluorescence on the thin layer chromatography. Fluorescence, it just enhances the mycolacton so that you can view it under UV lamp. That is basically the principle that we operate with. Now, interestingly, when we evaluated the method from, like I said, since 2014, on a total of about 449 suspected cases across regions, not just in Ghana, we found out that our sensitivity is 66.4. And we observed across all regions that this method was being implemented similar challenges. The challenges were quite similar from all places that we tried to implement this method. One was actually because the method in itself is not quantitative, and as a result, there is also the issue we have to deal with, which is really what is key, because normally once we have these samples taken from patients, what we observe is that in our extraction procedure, we tend to co-extract other human tissues, fatty matter in the samples, and it tends to give us background interferences. And sometimes it makes the reading very difficult and subjective to whoever is reading the results. So what we intended to do in this report was to, one, in trying to address that issue, is there a possibility of finding alternative boronic acid as opposed to our original naphthyl boronic acid, so that to see whether the fluorescence in those ones is more enhanced, so that we can, to make viewing easier for any lay person who is reading the results. That was the first step. And second step, by passing, which is not the focus of this, what we try to do is find a quantitative method, which we employ the quantitative thin layer chromatography, basically employing the same working principles of the FTLC method. But this time around, you are able to quantify the amount of mycolacton. That is work that is still ongoing. But with regards to the final alternative boronic acid, which is key to what we are presenting today, what we did was to screen a total of 27 commercially available boronic acid using the same protocol that we use with our original boronic acid. And we found interesting results. Out of those, we found 3 candidates, leading candidates, out of the 23 boronic acid. And among those 3 leading candidates, BA18 for short was the one that gave us a very promising spot, fluorescent spot on the TLC. So again, for this, you would have your sample, or be it sample being spot on your TLC plate, and then you prepare a solution of your boronic acid as a stain, and then you basically stain the plate, and then you view under UV light. The chemistry, as I said, is basically what I'm explaining. So what we did was to compare those 3 against our original boronic acid. So the first panel is our original boronic acid, and then the other 3. But we noticed that BA18, which is this, actually gave us very fluorescent spots on the TLC. With this, what we did actually is, so on UV and on a fluorescence measurement, the reason we are observing that was actually because this is the chemistry aspect of it. The Stokes shift for the selected boronic acid we observed was actually much wider, and that is resulting in our high fluorescence that we observed. But on the B graph, what we dip, without dipping the boronic acid, the plate in the boronic acid, it was almost impossible to view the mycolacton spot on the TLC. However, when we dipped it in and then heated it to cause the reaction that I described earlier, then we would see the fluorescence much more enhanced. Then what did we do? With the help of a team from Agogo, we got very classical samples of BU, because we wanted to compare our boronic acid with that of the new boronic acid that we think it's better. And then so for the top panel, what we did was to, the same protocol, use our original boronic acid, which is the BA, and then the new boronic acid, which we think is a better candidate than the original, which is the BA18. And then what we observed was that the BA18 actually gave us much more clearer mycolacton spots on TLC as compared to the original BA. Just for those who do not understand what is happening here. So what we would do ordinarily is to spot our mycolacton, synthetic mycolacton, which is a kind donation from WHO, on the right side, left side of the panel, and then spot our sample that is taken through treatment in the middle, and then do a co-spot. Co-spot basically a mixture of your synthetic microlactone and then your sample, and then we'll dip it in the solution, elute it and dip it in the solution, and then view under UV. So clearly, let me just take this panel for instance. You would notice that in here, it was almost impossible to view our microlactone. And then here, clearly you can see the microlactone spot in the middle, which is an indication that this is a positive case. Again, in here, for somebody who is basically trained to view these results, because the method is not quantitative, we have issues where we have misdiagnosis and then sometimes miscall of the results, because when it's not too clear, it's almost difficult to be able to call the results. Now, again, we repeated that using here, I just picked only the BA18, our leading candidate. We didn't do that I didn't provide the results for the original boronic acid, where we take negative samples and then analyze the same way and then view under the same conditions. And these were the results that we had. So clearly, in here, we would see a spot here that appears to, most often somebody might miscall that as a positive case. But what happens is that the reason why we do a co-spot is once you see a spot here, which is actually different in color to what we expect, but just for control, we put in a co-spot, and then you can clearly see a spot that is slightly above the co-spot here, which is an indication that this is actually a negative test case. So overall, this work was published, but on a limited number of cases. And what we can say about...
The time is now
okay.
1 minute.
Let me just conclude shortly.
Yes.
Yeah. So what we can say is that the initial results are very encouraging, but we actually would need more clinical samples for further evaluation of this technique using the new boronic acid. New boronic acid that we found more promising. But the challenges that we face is the declining number of confirmed cases, and then mostly funding. Because, like I said earlier, we are actually trying to evaluate the use of the high-performance thin layer chromatography, which is more quantitative for the detection of the microlactone using our new boronic acid. So funding is key in here, and then the number of cases as well. So in conclusion, BA18 possesses superior fluorescence as compared to the original boronic acid that we were using earlier. Because it gave, in clinical samples, it gave a more superior thin layer chromatography profile. So it's actually a potential replacement for our original boronic acid. We just want to acknowledge the following institutions and that have played various roles in this work. Thank you very much.
Thank you, Dr. Richard, for this presentation. We have now question. I see you. Dr. Lydia, first.
Okay, thank you, Gideon. Two questions. First one, what's the minimum amount of synthetic microlactone you can detect?
Okay, so the minimum amount of synthetic microlactone is actually, so on a synthetic microlactone, 2 nanograms is enough to detect it. But again, like I explained earlier with with reference to samples, what we observe actually is when you are dealing with clinical samples, we actually do not know the amount of microlactone that is present in the sample. And then again, the issue with background co-extracted materials that come with it. Normally, if the sample, normally with the when you are spotting the clinical sample, for the fact that we do not know how much microlacton is present in it, and also because of the co-extraction of other materials, we actually spot more in the sample. So we spot 40 nanograms of the microlacton, and the same equivalence in volume of the sample, just to be sure that you'll be able to detect if there is a presence of the microlacton in the sample.
Okay, so now you've given me a third question,
Yes.
but maybe I'll talk to you about it later.
That's right.
Is there a possibility of conjugating another compound or molecule to
Yeah.
either the boronic acid or another site on microlactone to amplify the signal, if possible?
In fact, that is a good question. That is actually what we are currently doing, where we are basically synthesizing a number of boronic acids. In this case, we are linking them to various dyes or various fluorophores, which have beneficial uses in other clinical settings. So we basically would conjugate, because the boronic acid unit is what is very relevant in this study, because it's that unit that is able to coordinate with or complex with the microlacton. So the thinking is, if we can synthesize other compounds or fluorophores using dyes which can further enhance the fluorescence, then that would be the game changer. So that is actually the work that we are doing at the moment.
Dr. Richard, for these answers. Other question? Dr. Valerie and Isra. Dr. Balogi de last.
Yep. Okay, thank you. So thank you for your presentation. I wish to know if you work with isolate or preserved in the laboratory, or you collected samples from the...
Definitely collected samples from the field.
So collected sample from the field?
Yes, so we work hand in hand, like I said. So for the first part of the work where we had to do the comparative study, the evaluation, normally would collect the samples together with PCR. One sample goes for PCR analysis, and then one sample goes for the microlacton detection.
Okay.
Difference is our sample is collected in a different medium, which is absolute ethanol, because the microlacton is preferably conserved in absolute ethanol, stable in absolute ethanol.
Okay, that was my next question, because I wanted to know how you were able to preserve the microlacton stability from the field to the laboratory to be able to have the positive result.
Yeah, thank you. So, like I said earlier, basically we have actually observed that the microlacton is quite stable in absolute ethanol. So we take the sample in that medium and then transport to the lab for further analysis.
What do you mean by quite stable?
I think the word is stable. Because the reason I use quite stable is also because we work with time. What we observe over the years is, in fact, we've had instances where samples were shipped to other labs and then were analyzed much more later, and then we couldn't detect the microlacton. So it's also a possibility of decomposition, especially if it's not stored properly. So that is the reason why. So for instance, when we go to the field, even though PCR samples, they can take the sample, basically put it in the swab tip and then transport it, and then you can still detect it. What we normally do is to foil our sample tubes with aluminum foil, because one other thing that is worth noting is that the microlacton is prone to photodegradation. So you do not want to have it exposed to the sun. So you can have the medium, all right, ethanol which the microlacton is stable in. But if the storage condition is not right, and then the transport system is not right, you would have an instance where the microlacton could possibly decompose. Yeah, but as for stability, it's actually stable in absolute ethanol.
Thank you, Dr. Richard, for these answers. I think now we move to Isra. Your question, please.
Sorry, thanks very much for your presentation. Actually, I have to say that I'm a believer of microlacton. I really think it's a very, very interesting target. But having worked with that for quite some time, I think it's unfortunately very challenging, no? If we want to use it for test development. But I believe that this type of studies are still interesting. It's important to try to understand what is the amount of microlacton in tissues, as Lydia has questioned before. There is very little information, and this type of studies, together with studies on real samples, could be maybe contributed to further development. But having said this, when we are working on diagnostic test development, I think it's important that we also look at the landscape and what is coming, no? And having seen how thermal chromatography works in laboratories in Ghana, and knowing that there are currently portable PCR or nucleic acid amplification tests that are coming and that will have better performance than thermal chromatography as it is, and they are less complex to operate, and this type of technology can be used across other diseases. My suggestion would be that we should continue studying microlacton, but not thinking in thermal chromatography as a potential test, but thinking on what can thermal chromatography or this type of studies bring to know more about microlacton, so we could use it in different test formats. But thermal chromatography as it is now, I really think it's not easy to conduct. Yeah.
Thank you, Dr. Isra, for comment, for suggestion. The last question for Dr. Barogi, please.
Yes, it's not a question. Thank you for providing the update regarding the study. I know we have started this study several years ago, and I want to know how many countries still involved in this study, and because I remember that Benin have been involved before. I'm not sure if Benin continue to provide the sample. Now, the main question is to know, when did you expect to have the final conclusion of this study, since the number of cases are decreasing and the number of countries participating in this study? So, thank you.
Thank you. I think it's rather a comment. Yes, of course. As I stand here, I can't give a timeline as to, because it's basically the validation of the method basically would require samples. And if I do not get the samples, it will be almost impractical to say within 3 months or within 1 year, then you would have a method that is sufficiently validated for use, or I don't know if that is.
Thank you, Dr. Richard. I think good job, big project. Now you have the first time for this research session. We make the break for the lunch, 1 hour. 1 hour. Yeah. No. Non. J'ai pas compris. Docteur Povsa Doudou, on a le temps, vous passerez l'après-midi. Merci. Donc, you have 1 hour break, and enjoy the break. Enjoy time to more discussion and interaction. Thank you.